functional definition of this is any pain that persists beyond the expected duration of pain. You see, patient has had surgery, the pain will last for a week, 2 weeks, or so. So any pain that lasts beyond the expected duration should be considered as chronic pain. To discuss this, friends, we have three very eminent speakers. I'll not introduce them, I'll leave it to the moderator. The moderator, well, we have a very senior and a very accomplished pediatric anesthesiologist, although she does obstetric as well, but pediatrics is her special interest. Dr. Ranju Singh, and well, I believe that anyone who is concerned with academics and is actively participating in various programs, various conferences, would have met her, would have listened to her talks on various platforms. Just for the information of the new inductees into the program, I would like to introduce her that she is Director Professor at Lady Hardinge Medical College, New Delhi, and associated hospitals. Her interest in pediatric anesthesiologist is shown with the fact that she established a Delhi chapter of Indian Association of Pediatric Anesthesiologists, of which she is currently the president. Earlier, she's been the vice president of Indian Society of Anesthesiologists, Delhi chapter. Plenty of awards: Academic Excellence Award in Medical Sciences, the Honorary Fellowship of Indian College of Anesthesiologists, ISA Delhi President's Appreciation Award 2022, ISA Diligent Award 2022, and the COVID Warrior Award as well. Academically, she is AHA accredited BLS and ACLS instructor, senior faculty of Airway Management Foundation, faculty at MET workshops, examiner, DA, DNB, MD, reviewer of various national and international journals, has more than 250 presentations at various platforms, publications more than 70. She's assessor for National Board of Examination and National Medical Commission as well. Well, friends, I would hand over the mic now to Dr. Ranju Singh for carrying on the program from here on as a moderator. Over to you, madam. Please go ahead.
Good evening, sir, and thank you very much for that very kind introduction. We are discussing a very important topic today. Although it's not very commonly discussed, all of us who are doing a lot of pediatrics do encounter a lot of acute pain. But where do the patients of chronic pain, the children with chronic pain, go? Do they go to the pediatrician? Do they go to specialized pain physicians? We will find out in this webinar. And chronic pain in pediatrics is somehow not very frequently discussed, in spite of the fact there are a lot of children with chronic pain, which could include a wide variety of etiologies from post-surgical pain to cancer pain. They do have a lot of suffering and functional disability and healthcare responsibilities, but somehow the economic burden on the healthcare system is relatively less. Probably they don't make man hours, and it's a topic which is not very frequently discussed. So today we are going to discuss this important but less frequently discussed topic. We'll talk about all the factors that are responsible. There has been a resurgence in literature regarding patients with pediatric patients with chronic pain, and there is data now available which talks about the risk factors and treatment modalities. There is, however, still less data that guides the physician on specific management strategies. So we have a very eminent galaxy of speakers today to discuss this pediatric pain. If Ankita will allow me to share my screen, I will.
Yes, ma'am, you're allowed.
Thank you, Ankita. I will be sharing my screen and show you the CV for Dr. Nitin. Just give me a minute. Okay, can you see my screen?
Yes, we can. But nothing has appeared as.
Just a minute, sir. I think a little lag here. Right. So Dr. Nitin is a professor of anesthesia at Lady Hardinge Medical College and Associated Hospitals. He's a dedicated pain physician. He has interest in addition to acute and chronic pain in critical care and has a number of indexed publications related to anesthesiology and pain. So Dr. Nitin will be talking about a very important topic related to chronic pain, that is post-surgical pain in children. So I invite Dr. Nitin to please deliver his talk. And we will be taking the questions in the chat box all through the topic, but we'll discuss them at the end of all the presentations. So welcome, Dr. Nitin, and we're eagerly waiting to hear you speak. Just. Is that okay? Can we see Dr. Nitin and hear him?
I think this screen needs to be unshared
Just a minute.
so that Dr. Nitin can come in.
Yeah. I have stopped my sharing, Ankita.
Yes, ma'am.
I've stopped my sharing.
Sure, ma'am. No, ma'am, it's already presenting.
Right. I've stopped the sharing so that Nitin can share his screen.
Yes, ma'am.
Thank you. Nitin, all yours. Nitin, you can start your screen sharing. Yes, thank you.
Visible, ma'am?
Yes, yes, absolutely. Please carry on. Thank you.
Thank you, ma'am. Good evening, everybody. I will be discussing about chronic post-surgical pain syndrome, and especially in the pediatric population. So, I will be going through the definition, the incidence, the risk factors that are associated with the chronic post-surgical pain, the pathophysiology, how this pain becomes chronic, the clinical presentation, and the management that is mostly focused on the prevention and the evidence for that. So, chronic post-surgical pain is recently described in 1998. It was first described by Trombe and McCrae et al. And basically, they found the incidence following the surgery as well as trauma, the incidence of the chronic pain after 6 months. And they found that the incidence after chronic pain after the surgery was around 22.5%. So they basically put forward for the further research in this field of pain. But since even after the 10 years of, we were not going ahead because there was lacking in the definition of the entity, what is chronic post-surgical pain, when we call it as chronic post-surgical pain. So then Dr. McRae et al. Came up with the definition of the chronic post-surgical pain, and the pain must develop after the surgical procedure. The pain should be of at least 2 months duration, and other causes of pain have been excluded, and the possibility that the pain is from a existing condition has been excluded. So just to guide the researchers so that they use a simple single standard, they gave this definition. But with the advent of the other like ISP, ISSP, so this was further modified by Werner and Kongsgrad, and they gave certain criteria for definition of CPSP, that pain should develop after surgical procedure, or the pain, if there is already there at the site of the surgery, it increases in intensity after the surgical procedure. The duration they came at 3 months, and it significantly affects the quality of life. Um, So this was another important thing that they introduced, that it may be a continuation of acute post-surgery pain or develop after an asymptomatic period. So basically, as we see the pathophysiology, the sensitization may not develop just at the post-operative period. It may develop after some time. So the patient may have a lull period, following which the pain again may start. Pain localized to the surgical field, projected to an innervation territory of a nerve situated in the surgical field, or referred to as dermatome. And other causes of pain should be excluded. Um, so why knowing CPSP is important in pediatric patients or in any other patient? So if we can see that in ICD-11, International Classification of Disease, it has been recognized as a diagnosis. The number of surgeries the children are undergoing, all as well as adults, if the incidence is 3 to 38%, the plethora of the patients suffering from chronic pain will be very high. So, though it has been said in literature that pediatric patients suffer less, the incidence is less, but then also the 3 to 10% to 38%, it all depends on the type of surgery. So, if the inguinal hernia repair, the adult report is 3.2%. If they are being reported at the child time, it is 5%. And depending on the surgery, so thoracotomy, major surgery, 16%, sternotomy, 21%, scoliosis, 19%, and the amputation. So it depends on the type of the surgery. So as well as it is also important to study CPSC because the literature is very limited. If you've seen this, these are all retrospective studies. These data has all have been gained from the retrospective studies. So the patient have been followed. There are very less prospective studies in the CPSP for pediatric patients. And we know that CPSP, if it is severe, moderate to severe, it significantly there is a functional disability, poor quality of life. There is a days of the school patient is not going to the school, the increased healthcare cost, and this will lead to increase in the anxiety and depression in parents also. So this anxiety, depression, and somatic complaints will pass on to the parents and vice versa. So when we say the risk factors, so there are a lot number of risk factors have been defined in the literature for pediatric as well as adult chronic post-surgical pain. And we may say like preoperative factor, intraoperative factor, or post-operative factor, or like this in patient-related, anesthesia-related, surgery-related, or patient is having pain. So one of the most important thing that is the risk factors is the preoperative pain. If patient is suffering from an acute or a chronic pain at the surgical site since 1 to 2 months, that is the most important risk factor for the development of chronic post-surgical pain. Apart from that, preoperatively, the genetic factors. So we have seen in most of the studies that some of the genetic factors may preclude a patient to develop an acute pain more in some patients and less in some other patients. So genetic factors may play a role. Anxiety, the psychosocial, the anxiety, the sensitivity, the previous, the parental and the child pain catastrophizing behavior. That has been the most important thing. So a patient is going for a surgery after 2 weeks, and his parent is not being able to sleep for 2 weeks. The child will see that parent is very much in stress, or is very much worried about his surgery. So he will again start catastrophizing the surgery as well as the pain. So this behavior has been most important. Sleep disturbances, depression, and other things like concomitant radiotherapy or neurotoxic chemotherapy. Intraoperative nerve injury has been a matter of debate. So in some studies, the nerve injury have increased the incidence of deafferentation pain, but in some studies, the incidence of the CPSP has actually reduced if there is the surgeon have cut the nerve. So this is a gray area. But we see when we will discuss in the presentation also, the most of the patient is having neuropathic component. So there may be some component of nerve injury also. Apart from that, the duration of operation. So duration of operation, more the duration of operation, more is the surgical tissue handling, tissue destruction, tissue edema, and injury to the nerves, and more is uh, the incidence of chronic post-surgical pain and intensity and duration. So this has been the most important factor. That is the intensity and duration of the acute post-operative pain is the most important association with the chronic post-surgical pain. Apart from in adult, we have other they are not important for pediatric, like female sex and living alone and other things. But in pediatric patients, these are not important. So now comes the pathophysiology. I already have discussed that it may be have a nociceptive or a neuropathic component. The nociceptive basically is the inflammation or edema at the local surgical site, ischemia or pressure or traction at the local site. But the most important and most studied the pathogenesis, pathophysiology for the development of the chronic post-surgical pain is the peripheral and the central mechanism. And of these, most important is the peripheral sensitization, followed by central and spinal cord. So basically, when there is a tissue injury, there is a release of the inflammatory mediators following the tissue injury, and it will lead to the accumulation of the BDNF, the capsaicin, activation of the TRPV1 receptors, and there is an action potential to the spinal neuron. If this peripheral sensitization remains unabated, it will eventually lead to the central sensitization and followed by the spinal cord neuroplasticity. So these three are the most important mechanism for the development of the chronic post-surgical pain. So central sensation basically again involves the release of substance P, the the BDNF, the CTRF, and the again there is a firing from a dorsal horn to the brain. Recently, not more recently, but the effect of the glial cells for the propagation of this chronic pain has been extensively studied, and they said that the inflammatory mediators that are there in the peripheral, when they go into the central circulation, they activate the glial cell near the spinal cord, and again they may be an important landmark for the further studies. So clinical presentation, if we have already seen that around 40 to 50% of the patients have neuropathic presentation, and around similarly they have nociceptive, and we have to find out the recurrence or the infection at the surgical site. So prevention, basically when we say about the management comprises of prevention of the chronic post-surgical pain rather than management of the chronic post-surgical. Prevention starts from the preoperative period. So preoperative assessment, identification of the preoperative risk factors like pain, the genetic predisposition, the psychological, and the if we are like CYP2D6 have been reused in the Western world for the genetic diagnosis of the chronic pain or the acute pain. So regarding this preoperative assessment, there was a pediatric pain screen tool that is already there, and it was used for the assessment of uh, uh, it predicts the functional and the chronic post-surgical pain outcomes after major musculoskeletal surgeries. That was published in 2022 in January. And basically, there are 9 criteria. The initially are the psychosocial, and then are the physical. And the low risk, medium risk, if there is a risk of more than 2, so they may have a more propensity to develop the chronic post-surgical. This is how we identify the patient who may develop chronic post-surgical pain. Another important thing is the preemptive analgesia or preventative analgesia. There are 2 important things, preventive and preemptive. So first we will discuss, there has been a lot of discussion about the preemptive analgesia having a role in the prevention of the development of chronic post-surgical pain. And so a lot drugs have been given like gabapentinoids. They lack aggregate, they lack a significant effect. The ketamine in some studies have found have a positive findings, but uniformly not so. Epidural has been, but depending on how it has been given. So preemptive has not been a very much efficacious modality in prevention of chronic post-surgical pain because we are too much focused on the time of delivery. We are focused just before the incision, the delivery of the analgesic agent. It may be of a very short duration. A short duration block reduces inflammatory trauma pain, but not reduce the central neuroplasticity, neuropathic pain that is developing during the surgery and at the end of the surgery. So we have just focusing at the incision site. And surgical incision, as we all know, is not the only cause of central sensitization. Intraoperative and postoperative noxious stimuli also contribute to the central sensitization. So this was a study that was a comprehensive meta-analysis that was done in 2005 and efficacy of preventive analgesia for acute postoperative pain management. And they found that preemptive epidural analgesia provided potential clinical benefit. So preemptive continued in the postoperative period in managing postoperative pain, decreasing the requirement for supplemental analgesia and prolonging the time to first rescue analgesia. And apart from that, the local and NSAIDs. So as we have already seen, that anti-inflammatory mediators may have an effect at the glial cells. So a multimodal analgesia also reduces the inflammatory pain. So following this, if we see the role of preventative versus preemptive. So here I would like to emphasize on the differentiation between the preventative and preemptive. So now, like this is a surgery. So this is a nociceptive input at the start of the surgery, and it goes throughout the surgery. And the hypersensitivity of the central or the peripheral and central starts and goes unabated. We give post-surgical analgesia. At this point of time, this is reduced. Again, this hypersensitivity is not controlled with the help of post-operative. When we see pre-surgical analgesia, this part is taken care of. This part is taken care of, this hypersensitivity. But again, when it is not of the long duration, it will again lead to hypersensitivity in the post-operative period. So there comes the concept of preventative analgesia, that is pre-surgical as well as post-surgical analgesia. We start from before the nociceptive input and continue throughout the post-operative period. So this is the ideal way of for prevention of the chronic pain. So moving ahead with this similar, this was a study in, there were 4 groups. First group was IV, intra-op, IV, post-op, the same drug. This was IV, second group was IV in the initial part and epidural in the post-operative part. And the third group was epidural, same drugs were given in the IV like lidocaine, clonidine, and ketamine. Epidural in the first half, post-operative, it was converted to IV. And the group 4 was, all the drugs were given initially epidurally, intra-op, as well as post-op epidurally. So, so the hyperalgesia was significantly higher in the intravenous group, and more patients reported residual pain from 2 weeks until 1 year. So when we see at the end of 1 year, the epidural and intravenous and epidural group had no patient who had residual pain at the 1 year as well as at 6 months. So they found that clear benefit of intraoperative epidural in preventative treatment and provides a higher benefit than only postoperative epidural. So how to go about? So this was just a recent article. So they have advocated for the development of a pediatric transitional pain service to prevent the complex chronic pain. So basically, transitional pain services aim to close the gap between the acute postoperative pain management and pain management after discharge from the hospital. So this team provides a comprehensive multimodal pain management and prevention techniques to children at risk of developing chronic pain. First, they identify the patient who are at risk of chronic pain. They do a comprehensive management protocol, opioid stewardship, provide opioid stewardship for children at risk of for chronic pain, facilitate the continuity of pain care for children across transition between inpatient to outpatient. So this has been advocated. It is very difficult to follow in our country, but that may be a step forward. So now, shifted our focus from timing of analgesia to protective and preventative strategies to decrease sensitization. An active intervention should continue for as long as the sensitizing stimulus persists into the postoperative period. But is it feasible to do in all the patients? You start epidural pre-op and do in the post-op. I think it may not be feasible in all the patients. So basic advocacy is accurately predict and identify the susceptible patients who are at greatest risk, and then go for a targeted prevention in this subset of. So, so now another important part in the management is the diagnosis of your the nociceptive and neuropathy. So earlier, all the chronic post-surgical pain was considered as neuropathic, and with the advent of this quantitative sensory testing, we were able to find out, and with the questionnaires that neuropathic or nociceptive, we were able to find out that around 50% have been nociceptive and 50% have been neuropathic component more. The management, when the patient comes into the pain clinic, the management is similar to other nociceptive or neuropathic pain condition. We go for physical therapy, psychosocial therapy, and then we go for the drugs that are mostly anticonvulsants and tricyclic antidepressants. But mostly we go for topical lidocaine patches for they are amenable to get it. Melatonin sometimes can help with the sleep disturbances, but also has been found to have analgesic, anti-inflammatory, and anxiolytic. So these are our management strategies. Thank you.
Thank you very much, Dr. Nitin. That was extremely informative, gave so much of information about a topic which we know so less about. You know, my experience with the pediatric patients with chronic post-surgical pain arises from the fact that since I work in a high volume pediatric center, many of these patients who come for re-surgery or a repeat surgery may complain of post-surgical pain from the previous surgery. So we do encounter these patients fairly frequently, and I wonder why there is not much talk about pediatric post-surgical pain. Thank you so much for that very informative talk. We will be discussing more about your topic once the rest of the topics have finished. So now I welcome Dr. Debesh Bhoi, who's also going to talk about one more relevant aspect of chronic pain in pediatrics, that is the pain related to pediatric cancer. Now, there is so much of literature available about adult cancer pain, but very limited information about pediatric cancer pain patients. You know, pediatric cancer pain patients do cite that pain is the most distressing part of their cancer trajectory. This not only relates to the cancer itself, but also to treatment side effects and to the painful procedures that may be involved in the therapeutic management of these patients. The parents more and more are being involved in the management of cancer pain of children at home. So we do need to have more information regarding the management strategies of cancer pain. And Dr. Debesh is going to give us a lot of information as to the effective pain management resources for these patients. If Ankita will allow me to share my screen, I shall be introducing Dr. Debesh. Dr. Debesh is, can you see my screen?
No, ma'am.
Just a minute. I think there's a problem at my end here. Just a minute. Okay, Dr. Debesh is an additional professor in the Department of Anesthesiology, Pain Medicine and Critical Care at All India Institute of Medical Sciences. His areas of interest include acute pain management, peripheral nerve blocks, chronic pain management, including dealing with spine and musculoskeletal pain. He has interest in complex regional pain syndromes and often deals with patients who come to him with orofacial pain. He has a number of publications, both national and international, to his credit. He has received a travel grant from AACA 2021 Seoul, South Korea, and is a member of the American Society of Regional Anesthesia and Pain Medicine. I hand over the space to Dr. Debesh to deliver his talk on chronic cancer pain in children. Dr. Debesh.
Yeah.
You can share your screen now, Dr. Debesh.
Okay, ma'am. Thank you for the nice introductions, ma'am. Just let me share my screen. Yeah, can you see my screen, ma'am?
Yes.
Okay, so I hope my first slide is a little bit of dark because this is something the dark side of pediatric cancer pain. It has been a little bit of less studied or less discussed regarding this pain. Moreover, overall the pain is sometimes less is as if the children's or the pediatric patient doesn't feel the pain. So again, same thing happens with the cancer pain also. So let us consider regarding the definition of the pain, as already Dr. Nitin has advised on, already addressed in this. So in pediatric, the pain is the most common. In case of the cancer pain also, pediatric cancer, if you see, pain is one of the most common and one of the most feared symptoms on children with cancer and their families. So in this case, the families is also involved. So apart from the basic definition given by the WHO, that is the unpleasant sensory and emotional experience. That is the most important part that is involved in children, associated with the and resembling that associated with the actual potential tissue damage. Obviously, there is something beyond that. So just I will just deal with some of the roadmap of my slides are just to deal upon the health burden, how exactly the situation is, how will you assess management plan and the what are the regarding the barrier and the solutions. These are very important. So this is a very good article in European Journal of Pain published in 2001 regarding the cancer pain management in children. As Dr. Ranju said, the literature in the pediatric pain management or in the cancer pain, basically, it is very scarce. Hardly you will get any randomized controlled trial or the whatever the evidence in literature is basically case studies, some of the experience, retrospective studies, and the good studies they has come up from the good, very good institute from the your sick children, the hospital sick kids from the Toronto, some of the from the your from the one the very good study from the Tata Memorial Mumbai. So if you see in the WHO has specifically addressed these issues as a document, that is the cancer pain relief and palliative care in children in 1998. So that advocates the global application of the principles of pain management and palliative care. So if you see the principle of pain management, they specifically design some of the principles that should be followed in such cases regarding the WHO ladder, appropriate opioid use escalation, that is normally people used to afraid of to do that. Use of adjuvant analgesics, that is a very definite role in some cases. Use of non-pharmacological methods of pain control. These principles of pain management should be incorporated into the treatment protocol. This is very important in child with cancer. So any cancer patient or any cancer patient, including the pediatric cancer, the pain management part should be incorporated in the treatment protocol because the pain is inevitable in something related to somehow this. So if you see, it is obviously the cancer pain is experienced the most of the 55% of patients undergoing treatment for cancer. 66% of patients who have advanced metastatic or terminal cancers. And if you see the pain relief improves the quality of life of the patient with cancer. Sometimes the terminally ill patient, they need a pain-free death. Sometimes the terminally ill patient also need very good pain management in those cases. So the various studies that you has reported, if you see about 50% of pediatric cancer of the outpatient nowadays, more and more outpatient patients are also there at the inpatient. So if you compare the pain part in inpatient versus outpatient, most of the inpatient that receiving treatment for the cancer or some of the admitted for the issues related to the cancer, the prevalence of pain is 84%. It is very high. And in this, 86% has a moderate to severe pain. However, in case of outpatient, those come for some of the treatment or some of the procedure like that, prevalence is 35%. Here also 35% has a moderate to severe pain, and these are very highly distressing. So this part should be taken care of. If you see the distribution of the cancer in children in pediatric oncology world, if you see leukemia, one of the hematological malignancies, is very common in children. That's gives the highest number. Solid tumor also, it's not behind the scene. Having sarcoma, most of the time you see the patient getting operated for Ewing sarcoma. Some of the patient getting biopsy from a Hodgkin's lymphoma or some of the neuroblastoma. These are the patients normally we encountered in the routine practice also. So some of these patients might be undergoing treatment for a solid tumor that might later on might go for a post-surgery pain, or might be some of the procedural pain, might be some due to some treatment plan. So these are basically the numbers of cancer that are in this case. So why am I encountering the procedural pain? Because in children is the every time there is something is going on, the patient or the children has to be face a pain regarding a myelogram or a venipuncture, because again patient receiving chemotherapy or some agent, the vein is getting disturbed. So multiple time venipunctures are there. This is occupied the most of the time. Lumbar puncture, biopsy, others. These are the things that normally consider or composite make a very good amount of pain in such cases. Most of the time moderate to severe pain. So if you classify this pain regarding the cancer-related pain or syndromes, it might be acute or a chronic. So acute cancer pain syndromes might be, these are always, this might be a tumor-related or a non-tumor related. So it might be directly related to a tumor, suppose a bleeding, fracture, or suppose the peripheral viscous, or some of the severe vena cava obstructions. That might be acute cancer pain, or sometimes the non-tumor related, like a chemotherapeutic agent, suppose malo, they cause a neuropathy or mucositis, bone pain, acute exacerbation of the comorbidity. In some cases, patient is receiving treatment and underlying disease has been again come off, like a post-operative neuralgia like that, or some of the diagnostic or therapeutic intervention related, patient receiving some treatment or some diagnostic intervention. Those are also the pain related to the cancer. If you consider the chronic pain, some of the patient, because see the hematological malignancy might be, it is short duration. The patient might be the duration of treatment might be shorter in those cases, or the relapse has been occurred. But whether it can be solid tumor or those, in those cases, this might be more. So in these cases, the pain is persisting that. So that means the chronic cancer pain, it might be related to tumor, like a vertebral or pelvic metastasis. It's causing metastasis, a base of skull syndrome, might be a headache or facial pain causing some of the tumor that is sitting up on the maxillary nerve like that. Dural pain might be so hepatic distension syndrome or peritoneal castomatosis. Again, there is a post chemotherapy pain that might be non-tumor related. So there is the pain related to those also. My patient might be radiation therapy, enteritis or proctitis. Also, suppose a plexopathy or brachial or some bursitis. These are all related to the tumor, but again, the pain might be related to the not directly related to the tumor. So if you consider neuropathic pain, so pain, if you see the chronic pain in children, basically Dr. Nitin has already said about it. There is two types of pain basically, or I would say it is nociceptic pain. There is a tissue injury that causes pain, that is somatosensory systems. But neuropathic pain is something very very difficult to treat sometimes. Neuropathic pain, where there is a indirect or direct injury of the nerve, sometimes so that is associated with that, causes a neuropathic pain. It might be related to some of the treatment. So as in this case of a pediatric oncology, if you see a variety of types of somatosensory system injuries occur because of chemotherapy related neuropathic pain. It might be tumor related or post-surgical neuropathic pain. So there will be complex circumstances in neuropathic pain at the end of life, patient receiving on that. So if you see the vincristine, one of the agent that's normally very commonly used is responsible for the chemotherapy-induced pain. If you see the tumor-related solid organ tumor, that is suppose it is proximal to any nerves, that might cause the neuropathic pain. Suppose a cervical or malignant brachial plexopathy might occur. Sometimes again due to metastasis, the tumor metastasis causing a lumbosacral or that type of pain. Suppose a patient of osteosarcoma like that is undergone a surgery or phantom that can again lead to a phantom limb pain or the post-surgery pain that might be a nerve injury causing the neuroma type of pain. Again, the progression of the disease that causes again the pain. So if you consider the chemotherapy-induced neuropathic pain, it is one of the paper, very good paper. It is very extensively studied. But again, the problem is that everything that has been studied is a complex mechanism. If you see whatever the publications or published literature, they are that based on the adult one or the animal studies of adult rodents or a adult one. So that is just extrapolated in the pediatric one. There is a complex mechanism of the axonal injuries. So basically, the chemotherapy agent that causes us involve the microtubule or axonal generation, like that microtubule polymerization that attack on that, and that lead to axonal injuries and causes neuropathic pain. So it is always a dose-dependent manner or a duration of the treatment that patient is receiving. So if you see the damage of axon, immune cell, that is here at the nerve terminal of the dorsal root ganglion, there will be inhibition of the microtubules function or modulation of altered expression of the ion channels might occur. There be again the level of spinal cord. If you see that activation of microglia and release of pro-inflammatory cytokines, these are again can lead to chronic pain or neuropathic pain. So these are so in this case, if you see the goals of treatment, suppose the patient is having this type of pain, obviously at the end of the treatment, the goal of the optimum pain management is the reduction of pain to a level which allow an acceptable quality of life. That is very important. Safety of the patient, healthcare provider, communities, and society must be assured. Analgesic, including opioids, must be accessible, available, and affordable. This is the WHO guidelines for the pharmacological and radiotherapeutic management of cancer, that for the pain in adults and adolescents. So it includes both from the Geneva Convention, that is, they have given integration of cancer pain management as a part of cancer care. It is very, very important. However, again, if you go to the literature, it's very disappointing. This is a very, suppose if you'll find a Cochrane review of opioids for cancer-related pain in children and adolescents, and what is the result? It's very disappointing. If you see, they have seen a 714 records through the database searching, and hardly there are any studies included in the qualitative synthesis. There is no studies in including the quantitative synthesis. So to give a idea, to give a roadmap or the protocol, there must be some just studies or control studies that is very sometimes lacking in literature, that need the long-term studies of the patient and follow-up the patient, that only can be giving the literature a good amount of evidence for the management. However, if you see a patient of untreated pain, what normally happens is the quality of life that affected. It might be in the term of sleep, pain sensitivity, procedural distress, social activities restricted, and emotional and behavioral problem. In case of pediatric age group, sometimes the preverbal non-communicative children, it's very time, suppose the patient is crying, the kid is crying because of the pain, you don't know. There is distress to the parents. Most fear symptom, that is the pain, it's very distressing for the parents. Sometimes it's difficult to assess in this case, and that's why undertreated also. So it's very important to assess the pain in this case, the discussion of the child. Suppose a child is older, so more than 5 years, it can discuss with the child. It's communication. It can just friendly with the child. He can give you the sign and symptoms, discuss with the child exactly how the pain is and how the pain is affecting his daily life when he is playing activities. Those can be assessed. Discuss with the parents, caregivers, staff. So nursing staff can give us some idea how the pain is there during the procedure, sometimes in the word. History and examination, sometimes the nature of a pain or the cause of pain can also you can elicit from. A brief history can give a site or onset, whether it is start, radiation, character, association, time course, any relieving factors, severity. So these are very important. So in this case, suppose those patients with that communication difficulty, a very small child, in this case, if it's crying or grimacing, frowning, these are basically different scales of the children's pain evaluation. In this case, that is the quest, it is short term, that is the question the child, use pain rating scales, evaluate the behavior and psychological changes, secure parents' involvement, take action, evaluate results. These are basically evaluation of the children's pain. In neuropathic pain, there is a specific, the pediatric modified or total neuropathic scale, basically the first reported screening tool. It's very difficult in children to assess those things. So that is the only scale that is initially that described, and later on some of the scale that is validated from the ages to 5 to 18 years of child. These are some of the signs and symptoms that can just identify the neuropathic pain to diagnose that. In that case, some of the children can be asked regarding those pain. Some of the pain that normally also you can use for the acute pain, like that descriptive pain scale, like a mild, moderate, severe. It is simple to use, limited number of choices, ease of scoring. Numeric repeating skills, some of the time the children can tell in the number of 10. The problem is that suppose the pain is very severe. So more than 10, how can you tell? So the other some of the limitation in this case. Flag scale and the Keough scale also used in the pain with the patient is having a very good amount of pain. So always assume that pain is present unless there is evidence of absence of pain. That is the fear of pain or the treatment or fear of injections is there. So this is the dictum in children. Come to the management part. It is a non-pharmacological, pharmacological intervention. It is a broadly divided in all the sort of these cases. Cognitive tools and the behavioral tools. These are the very important. So that in this case, the stress management or distraction, sometimes the hypnosis during the procedures like that. So these are basically some of the technique that is normally used in these cases. Same for the child, and there is participant activities, simple exercise, relaxation training. These are basically non-pharmacological methods that is a very role in these cases. One is the scrambler therapy also that has used for chemotherapy-induced neuropathic pain basically. It's basically used as an electroanalysis device that consists of process that can generate non-painful stimulus, but the gate control therapy in that case. Application of surface electrode on skin over the painful area. Here, in this case, also children, also few cases, a series or reports has described this patient with chemotherapy-induced neuropathic pain has found good result in those cases. WHO ladder, again, it is a very important role from the mild pain with the acetaminophen and the paracetamol, the most commonly used drug in those cases. Sometimes ibuprofen is added, another drug depending on that. If the pain is moderate to severe, obviously the morphine or the strong opioid or these drugs is taken into consideration. There are different preparations of the morphine in case of children, that is sometimes immediate release preparation or the 12-hour preparation are there. But normally the syrup that is the doses are varies from age group depending on the 150 microgram orally, 6 or mostly it's started with 4 hourly, and then depending on the effect, it is escalated in that way. In case of children, basically, always the start with the 4 hourly dose, then the starting dose is around 0.2 or 200 microgram per kg. 4 hourly is the started dose. Then seeing on the response that is basically used. But sometimes if the tolerance occurs, or sometimes that might be rescue pain, or sometimes you have to consider the other opioid switch in such cases. In that case, we have to convert a oral morphine to the fentanyl-based patch support. So in that case, we have to consider the oral morphine dose in 24 hours. Then again convert to the around 1/3 if you say the IV morphine. The dose of IP morphine dose in milligram, that is equivalent of same fentanyl dose in microgram basically. And the same patch, if you consider the fentanyl dose in 24 hour, is that is the your patch dose that is normally required for that way it is calculated. Then if we say, suppose example, this is just a simple example, 20 milligram if it is taking, the total requirement 120 milligram, and again you consider the simple formula, then it might be 40 microgram per hour. But normally the available are your 50 microgram. Accordingly, it can be used, and in that way the nearest formulations. What's most important is the counsel of the family. Sometimes we have to, or is of sedation, respiratory depression, we have to very counsel the patient regarding those that are itching or pruritus that respond to antihistaminic. Sometimes the tramadol and codeine also used, but again, tramadol has a rose seizure threshold, and sometimes it is not commonly used for children. The morphine, the fentanyl is most commonly used. Adjuvant analgesic is a very important role. Sometimes the neuropathic pain like antidepressant, anti-epileptic is used, or sometimes for the painful muscle spasm like relaxant like baclofen, and for the brain tumors like steroids to raise the intracranial pressure that normally used by neurosurgeons in those cases. So gabapentinoids, again, it is that same thing. The studies are very less. If you find the adult dose, normally we start at 75 or 150 and go up to more than gabapentin because 3600 milligram per day dose. But in case of children, the doses is little less. So normally the gabapentin is started less, that is hardly 10 milligram per kg per day, and then up to slowly escalate over the weeks. Same from the pregabalin also, it can be used up to suppose if a children of the communicate children around 75 milligram that is normally used, or 50 milligram preparation is also available. It can be started. This is if you see other agent, that is normally the amitriptyline or the tryptamine or ketamine, lidocaine. These are also can be used in those sometimes the pain that is not controlled by simple other analgesic, then it can just mix up the analgesic in those cases of neuropathic pain. So they are basically, if you see the previous study, they have shown the paracetamol, as you said, is a very commonly used drug in the world also. So interventional pain management in cancer pain is very sometimes because of the refractive to conservative treatment, this can be considered, but still there is less reported. The report is very less in these cases as compared to the adult population. They are less frequently done, maybe due to fear of complication. The reporting is very less in this year. This is the most important problem is the pain management and use of opioids in pediatric oncology in India. This is a study, the authors are from Toronto and the TMC Mumbai. They have done a qualitative approach in India, basically what the problem basically. So if you see the barrier in pain management in these cases in oncology in India is first is financial issues sometimes. The patient may not be affording to the treatment basically sometimes. The lack of educations, awareness, and the lack of human resources, poor availability of opioid. So these are the major components that lead or the barriers in the pain management. If the parents are not adequate or illiterate, obviously that lead to the awareness is not there how to uh, go to the hospital and take the medication and like that. Lack of human resources in India, as you can see, if you consider the recent data of the year, the per 1,000 doctors or the healthcare personnel requirement is very less. So that might be one of the reasons for that, the poor lack of human resources. Sometimes even if you are producing the opiums, still the opioid availability is very less, or sometimes the accessibility to the opioid is the certification, those things are there. So those things are the awareness and education part is very important in these cases. So that's why in this article, they very easily described the possible solutions according to the interviews they found that increase the availability. That is the problem is the morphine availability, that increase the availability, increase the awareness of physicians and nurses. The big obstacle is awareness. People has to aware, healthcare provider. We need manpower. The issue is numbers. We have more number of patients because so now that cancer in India is not that it is number is less because of the increased diagnostic early diagnosis, and there are so many things are available. So more and more getting a diagnosis is getting more. So the incidence is relatively it has increased. So we need more number. That is the nurse, that is the oncology nurses. The nurses who is trained in this can do wonders. A nurse in the world can do wonders when she is trained to deal with those cases. The simple guidelines, the protocol-based guidelines, easily available, which can person can understand. It is something that we can work out. We need to have the more trained personnel. Sometimes every time you cannot get a trained healthcare personnel. So we have to understand that focus on people in the community or in the rural areas. So that is very important so that the healthcare can reach to that. Educate the parents. That is literacy is a major barrier. If the family is literate, they will understand and they will listen. So lastly, approach to a child with the pain, assess the pain with the child with pain. That is the, you have to devise the nociceptive versus neuropathic pain. Also, situational factors or account with the child's pain should be taken care of. Anything is your diagnosis of primary or secondary causes might be, that is cognitive, behavioral, emotional factor associated, or any nociceptive neuropathic component is there. Then the appropriate therapy should be considered, and the pain management plan should be again measure the child's pain regularly, evaluate the effectiveness of treatment plan, revise plan if it is not needed, rational for integrated treatment plan. That is very important. Thank you very much for kind listening.
Thank you very much, Debesh. That was a very interesting and informative talk on pediatric cancer. You've touched upon a lot of topics which were very unique to your talk and very different from adult patients. As I said, we'll take the questions at the end of the third talk. The third talk is an equally interesting topic. We will be talking about interventions in pediatric chronic pain. Now, we do have a lot of information about adult interventions, but do the interventions remain the same in children? Are they any different? Do they require interventions by a specialized pain management physician? Or can anybody who's dealing with pediatric patients, and any anesthesiologist, a pediatrician, can they look after these patients who have come to us with chronic cancer pain. We now will have this talk from Dr. Aanchal. She is senior consultant and head of pain medicine at BLK Max Super Speciality Hospital, New Delhi. She has a vast experience in such interventional pain procedures. She has a number of publications to her credit, both national and international, and I'm sure the audience will benefit a lot from her experience on interventional pain procedures in children. So I hand over to you, Dr. Aanchal, and we're eagerly waiting to hear your experience. Thank you. Yes, we can see your screen.
Ma'am, you're on mute, ma'am. Kindly unmute yourself.
Dr. Aanchal, we can't hear you.
Yes. Can you hear me now?
Yes, yes.
So, good evening, everyone. So, I'll be talking on interventions in pediatric chronic pain. So, the topic we will discuss, and we'll discuss chronic pain, its recognition, some of its myths. The interventions, we do as pharmacological, psychological, physical, and procedural. I'll share a bit of my experience, in pediatric chronic pain, and we'll be happy to take any questions, if any. So pain has already been discussed, the definition, chronic pain, and it's multifactorial because, it could be cancer-related, post-surgical, musculoskeletal, visceral, neuropathic, but just a word on chronic primary pain because it is a pain which happens in one or more anatomical regions. It is associated with significant emotional distress and a functional disability. And in children, this relates to not being able to go to school, not being able to play. So this is what the chronic primary pain is, where we are not able to figure out the cause. So there are some misconceptions I want to, talk before I talk about the interventions. Usually the myth is children experience less pain than adults. Children over-report pain. So if child is saying, like any adult, I'm suffering from pain, that means the patient is having pain. So children are too fragile to receive any potent drugs or narcotics, that may cause addiction. That could be true. But if we give the dose according to their body weight, if we think of all the comorbidities like we do in adults, they are equally receptive to all the drugs, and then they can benefit in the pain management. And if one is urgently trying to save a life, there is no time to worry about the pain control. And I'm sure this happens in adults as well because saving a life, obviously it's very, very important, and nothing can take care of that. But if you think of from the kids aspect, from a patient's aspect, his main problem is whether or not you'll be able to take care of his pain. So how do we assess? So I'll just go quickly, go through it because already previous speaker has, dealt with it. So we just simply ask the child if it's more than 3 years, and if the patient is not able to rate, we can show them the happy face, sad face scale, and they can just tell, how to which face their emotions correlate. And there are a number of behavior observation scales. The more important fact about all these scales are you can not use all of the scales, but if you are into a facility where you see a lot of pediatric patients, then you can just make a one observational scale as your go-to thing, so that everyone in your team is well versed with what it includes, and everyone understands and talk about the same language as related to the pain severity. So just because I'll be talking about the level of evidence, so just a revision about that. The one is when we talk about high quality meta-analysis, systematic reviews, and level 2 is just the systematic reviews of case control and cohort studies. 3 is just case report and series, and 4th is based on expert opinion. So coming to number 1, pharmacological intervention, is Dr. Debesh has extensively shared the number of pharmacological interventions. So just to touch on it, we have simple non-opioid analgesics, which is paracetamol, NSAIDs, lidocaine patches, especially beneficial for diabetic neuropathic and post-herpetic neuralgia. They are, the simple analgesics are good in non-malignant pain and even in the malignant pain in early stages, but they should be limited to the shortest possible duration. So this chart basically shows that we can use, acetaminophen as early as, as the child is born, even in the preterm, but the dosage should be just strictly, milligram per kilogram, and it needs to be given in the divided doses. And similarly, the NSAIDs. The only thing about NSAIDs is, only one drug needs to be prescribed, and these NSAIDs are not recommended until the child has complete 4 weeks of age or 44 weeks post-menstrual age. And after that, we can, carefully give it per milligram per kilogram dosage. Second is anticonvulsants. Low dose amitriptyline can be given for management of functional gastrointestinal disorders, and this is supported by level 1 evidence. The same anticonvulsants can be given for chronic daily headaches, chronic widespread pain, mixed nociceptive or neuropathic pain. When it comes to the use of gabapentinoids, they say that gabapentin should be considered as first line, and if it doesn't help, then probably you can think of going to pregabalin as a second choice. Then there are medications which needs to be thought of if there are for symptomatic management, like bisphosphonates for managing bony pain. Either if there is METs in cancer patient or in young people if they have osteogenesis imperfecta, then intrathecal baclofen for managing spasticity, because pain will not go until you control the spasticity. Or sometimes the pain is just because of the dyspepsia, then you can just think of giving this anti-H receptors. Then opioids, they're rarely indicated in non-cancer, and if you have to use, for example, in post-op pain, restrict to as short a time as possible with regular monitoring of its efficacy as well as adverse effects. And codeine is not recommended in children. And similarly is the tramadol. Coming to second, the psychological intervention. So why psychological intervention is given so much, emphasis, and especially in kids, because these interventions are based on understanding that pain is a complex biophysical psychological experience, and this is shaped not only by underlying pathophysiology, patient can have neuropathic, nociceptive, any kind of pain, but individuals' thoughts, feelings, and behavior. This also affects the severity of the pain. So the target age group is 7 years to 18 years, because by that time, more than 7 years, you can talk to kid and he understands what you're saying. So most psychological treatments for pain are designed to address these negative and fearful thoughts about pain. For example, is it going to hurt too much? If it is, I can't do this. So this thought itself, will produce psychological changes. If child is scared of doing something, and if you ask them to do it, it'll lead to tachycardia, shortness of breath, discomfort, and then the changes in the behavior. The children will just withdraw from the activity, or because of the lot of anxiety about doing that thing, they'll have the poor sleep and other issues. So there are multiple, treatment options when it comes to psychological, and the person responsible for taking up this up is the psychologist available in the hospital. They have, you can see the list of tools they can actually, use to take care of the psychological part. And the best in chronic pain is CBT. We talk about it all the time. At the CBT, it just focuses on changing your thought process, and just teaches you whenever the pain comes. It teaches you certain skills which you can do at that time, and it'll at least decrease the intensity of the pain. Benefits we receive just by doing psychotherapy is reduced functional disability and depressive symptoms, the greater improvement in coping skills, reduced somatic symptoms, anxiety, reduced frequency of pain crisis, and also reduced negative mood, self-esteem, and then hence improved school functioning post-treatment. And there are a number of studies which has been done on these kind of therapies, and all the benefits I'm listing is actually the conclusion of multiple studies which has been done on this CBT and other techniques. Then physical intervention. This is the third intervention. The range of physical therapies kids can do is exercise, aerobics. They can join the yoga classes, stretching classes, strengthening, hydrotherapy. By doing the group therapy, actually, it enhances child's confidence, and at the same time, it benefits that particular area where pain is bothering them. Then coming to the interventional procedure, before we discuss the interventional procedure we do on children, the guidance, the image guidance is must. Either you need to do a fluoroscopic guidance or CT scan or ultrasound, whatever you're comfortable with, or sometimes you have to just do a hybrid technique taking the help of the fluoroscopy as well as the ultrasound, wherever you feel comfortable with. But using just landmark based technique as we do in adults is a non-standard of care in children. So coming to the interventions, this is a chart, this is a table which shows that there are there are procedures which are being done in children. This is a table taken from one of the review articles, and you can see neuraxial blocks, peripheral blocks, sympathetic blocks, neurolysis, intrathecal baclofen, and intraarticular steroids. All these procedures are, you can see case report, 12 case reports, case series with 7 patients, prospective studies, retrospective study, a number of indications which we'll discuss as we go on, and all of course done with the help of image guidance. But these are all the procedures which we do in adults are being done in children as well. So if we talk about areas affected by chronic pain, then for example, in head, the chronic pain could be because of the migraine or persistent neuropathic headache. You can do peripheral nerve blocks like trigeminal or occipital nerve blocks or supraorbital nerve blocks. If the pain is in abdomen, neuropathic pain after the surgery, like the previous speakers talked about it, then we can do peripheral nerve blocks, depending on where the pain is, rectus sheath or transverse abdominis plane block or ileoinguinal. If the pain is very severe, we can do either single shot or we can do perineural catheters, which can stay for a few days. Then for cystic fibrosis or recurrent pancreatitis, the celiac plexus block, and for cancer pain, epidural or intrathecal analgesia. For chest pain, we can do thoracic epidural or intercostal nerve block, depending upon the area of the chest. If it's a single intercostal space or just 1 or 2 intercostal space, we can do intercostal blocks then versus thoracic epidural analgesia. And then there are multiple causes of back pain as well. The disc degeneration or spondylolysis. We think of, we don't think of these diagnoses in children, but children also, especially, if they are suffering from tumors or sickle cell disease, and then there is myofascial pain syndrome, and depending upon the diagnosis, we can think of doing the procedure. And the limb pain, the fibromyalgias or juvenile arthritis, we can do joint injections. Phantom limb pain, cancer pain, are managed by spinal, epidural, and regional blocks. Sickle cell crisis pain, myalgia paresthetica. As in adults, we do LFC and block. Similarly, in children, LFC and blocks are done. And for CRPS 1 and 2, the sympathetic blocks or neuromodulation or continuous peripheral nerve blocks. Whatever your plan comes, but all these procedures are being done in children as well. So coming to central neuraxial blocks, where we do epidural and continuous epidural analgesia, we do in cancer-related pain, back pain, sickle cell crisis, and then CRPS type 1, along with LA, we can mix the adjuvants to decrease the LA dose and increase their efficacy and analgesia. Then the intrathecal infusions have also been successfully utilized in children to treat cancer pain and CRPS1. I found out an example in one of the review articles where author used successfully treated an 8-year-old girl with chronic left foot pain, which was because of the CRPS, by placing an intrathecal catheter at L4-5 spinal space, and they kept it for a week, and they ran a regular infusion, just monitoring it carefully, and they were successfully treated an 8-year-old girl patient's pain. And then you can do intrathecal clonidine. Baclofen is it's extensively being done for treating the spasticity in children with multiple sclerosis, cerebral palsy, traumatic brain injury, spinal cord injury, transverse myelitis, Friedreich's ataxia, spinocerebellar ataxia. Excuse me. Then peripheral nerve blocks, head and neck blocks. Occipital nerve blocks are done for persistent posterior headaches and occipital neuralgias. Supraorbital and supratrochlear nerves are being performed at the level of supraorbital foramen. If you can see, this white thing where ultrasound is kept, you can see this bony area which is, like a white shadow, but there is a dip here, which is a supraorbital foramen, and just above that is a supraorbital nerve, and you can clearly see it and just do the out of plane technique. And these procedures are performed serially and can be easily performed in outpatient setting with topical anesthesia. Upper extremity, as anesthesiologists, we are very well versed with brachial plexus block. They have been used for intraoperative and postoperative analgesia extensively, but for chronic pain states, they have been used for adjuvant management of CRPS1 along with pharmacological management, neuropathic pain management of upper extremity, phantom limb pain, and cancer-related pain. And there are different approaches, know that, and ultrasound guidance is imperative. And coming to the lower extremity, we know that majorly 4 kind of nerve blocks are done when it comes to lower extremity: femoral, sciatic, lateral femoral cutaneous nerve block, and obturator nerve. So, the femoral nerve block for CRPS or in refractory pain, there are a number of case reports where they have done femoral nerve block if the child did not respond to the medical management after the chronic hip dislocation. In sciatic nerve block, they have placed a continuous catheter for reducing the CRPS-related neuropathic pain or cancer-related pain, and sometimes phantom lip pain. Then LFCN for myalgia paresthetica, so that there is long-term analgesia and patient can effectively do physiotherapy. Obturative neuralgia does happen in children. They present as medial thigh pain, where you can do obturative nerve block, and sometimes there is a spasticity in that area. And I found out a case report where the neurolysis of obturated nerve was done to treat that spasticity in children with cerebral palsy. So coming to the truncal blocks, paravertebral intercostal rectal sheath tap and ilioinguinal nerve blocks, depending upon where the pain is, like the way we choose the area in adults, these blocks can be successfully done in children as well, but with the help of ultrasound guidance. And then coming to the sympathetic block, stellate ganglion block has been successfully used in children to manage CRPS1 of upper extremity. Herpes zoster and the painful events caused by the Klippel Weber syndrome, Turner Weber syndrome, where you see multiple vascular problem where there is sometimes ischemia, sometimes thrombosis. So this is successfully being done. Lumbar sympathetic block has also been helpful where you have CRPS of lower extremity or vascular disorders. Even lumbar indwelling catheters, if you don't want to do RFA, you can just leave a catheter there rather than doing a repeated block. And this is very helpful in managing the pain. And then celiac plexus block for visceral pain because of malignancy or chronic pancreatitis. Then other interventional procedure in pediatric population is trigger point injections, where you do find the myofascial trigger points. And especially in the headaches as well, where you can do a certain supraorbital, supratrochlear nerve blocks. Then botulinum injections has been given to treat spasticity and dystonia, and intra-articular injections have been done in juvenile idiopathic arthritis and osteoitis condensans, where the patient complains of back pain, but you don't find anything, and then the X-ray shows osteitis condensus. And then without any significant side effects, the intra-articular steroid injections have been done. So coming to the complications, they range from mild to severe, and this is a similar complication as you see in adults as well. So we need to be, mindful of talking this to the patient if the child can understand, especially the parents. We need to explain all the above possible complications and consent the child accordingly. So my little experience with pediatric chronic pain patients, all these patients have been discussed here are actually more than 12 to 14 years of age. Less than 12 years, whatever small references I've gotten, I've just managed with the medical management. But these are the specific patients which we can help with the procedure as well. So the occipital neuralgia, this was a 17-year-old child. You can see, I just shown you can see, local anesthesia has already been given, and I'm putting my needle, and you can see the similar needle. If you can see my needle going in, and it is this semispinal scapularis, this boat-shaped muscle you see, and the target is this fascia, and the needle has already reached there. And and then you inject the medicine. It is seen as the hypoechoic, and then Then the another procedure I did was knee ACL cyst. This was a 18-year-old child who was suffering from knee pain since 2 years, which was progressively worsening. And the patient went to orthopedician. MRI was done. It showed knee ACL cyst. He was given an option of arthroscopic, drainage of the cyst, but the patient wanted some conservative management. So he was sent to me if we can do a needle aspiration. So you can do and keep an ultrasound here, and you can see, my needle. You have to use a thicker needle actually, and you can see this is a medial femoral condyle, lateral femoral condyle, and this is the cyst. You can see, and then the needle is reaching that probably. You can, so I'm aspirating. So this is probably a better picture. You can see the needle. This is the cyst. With the ultrasound, you can beautifully reach that area. And I was able to aspirate to 2.5 ml. And then following that, I did a PRP injection rather than injecting steroid. So the patient did have 90% pain relief after 1 week. Then coming to cancer pain, the cancer pain, what I do is I do multimodal pharmacotherapy. And then RFA or neurolysis of sympathetic plexus when indicated, like we discussed. This first one is for sure if the patient has bony pain according to the dose milligram per kilogram. And then, very, very important is supportive care in terms of oxygen requirement, home care in BLK Max. They have wonderful home care team, which takes care of any home needs a kid might have, because it might be difficult for parents to bring them all the time, especially under the palliative care. And the management of the side effects, of them, like peripheral neuropathy, if the child is suffering from, or constipation, or loose motion, or chest infection, anything, a lot of things happen in the palliative setting. So they're taking care of that as well. So fibromyalgia, widespread pain, there was a girl, 16-year-old, she came with this widespread pain, extensively evaluated by a neurologist and then pediatrician, nothing organically was found. And, we made this diagnosis of myofascial pain syndrome. I started her on low dose amitriptyline along with physical therapy, especially I encouraged her to do aerobics, and then psychologist helped her for the CBT, though she didn't attend, so many sessions. But, the pain was reduced, but she started getting amenorrhea for 2 months, and then she was sent to gynecologist, and she was found to have raised prolactin. So we have to stop amitriptyline. So we need to be mindful of the, the side effects, which these neuropathic, we just start the medications, but even the low dose, she was just on 10 milligram, and even this much of low dose caused the side effects. So that was stopped, and eventually she recovered with just the physical therapy and the CBT. Then myofascial pain syndrome, especially with the mobile use, this late teenagers, they get this neck pain, and there are trigger points here. If you can feel it, then this can be managed with short course of muscle relaxant, ultrasound guided trigger point injections, or you can just feel that muscle knot and you can inject, and physiotherapy and CBT as well. To take a message, I would say, chronic pain in children can be managed by various tools which are as effective as an adult population. Just because they are children, we if we are using the image guidance, we should be doing the procedure. Understanding pediatric anatomy is imperative, and hence is the use of image guidance, either ultrasound or fluoroscopy, while proceeding any procedural intervention, because these parts are technically challenging and must be done by qualified and experienced personnel. Multimodal approach, along with emphasis on psychological intervention. These are my references, and I'll be happy to take if there are any questions.
Thank you so much, Dr. Aanchal. Very informative, and we loved that you shared your experience of dealing with pediatric chronic pain patients. Now, we will wait for questions. Ankita, will you be posting the questions here in the chat box?
Yes, ma'am.
Okay, so there is one question already. I think this question is addressed to Dr. Debesh. Dr. Debesh, Dr. Muthukumar wants to know how to calculate analgesic dose of morphine in a patient who's receiving oral morphine. How to calculate analgesic dose of morphine in a patient who's receiving oral morphine.
Okay. So if the patient is receiving oral morphine, so normally, so we have to calculate normally the dose that is basically, if the suppose are taking a oral morphine, suppose a per day total, so that can be, see, the analgesic dose is something the patient to patient basis, case to case basis, basically. So the total dose that is required or oral morphine required by the patient is normally that is effective in treating his pain. So the normal conversion that normally oral to IV, suppose if you want to do a analgesic dose. So analgesic, suppose if you plan to in terms of IV, suppose, or something to convert to equipotent dose of any other thing, then obviously the oral morphine that total 24-hour dose can be converted to the IV at the 3:1 ratio that from the oral to IV. And the same, suppose if you want to convert to the fentanyl or some short acting agent, it can be depending on that already are given in the tables. That is where you can use that. So basically you have to use the effective dose first. You have to calculate how much dose is required for effective pain management, basically.
Okay. Okay. So now that we are on the topic of pharmacology for cancer pain, Debesh, is ketamine also an option for pediatric cancer pain? Ketamine and lidocaine, which we are commonly using for adult patients, are they options for pediatric pain also?
See, exactly. See, because see, the pediatric, that is normally if you see the ketamine and lidocaine, that normally you have seen that. So this patient cancer pain has a variety. The type of pain, as already said, it might be from nociceptive to a neuropathic pain.
Right.
So basically, at certain point of time, the neuropathic pain sometimes it might be not respond to a traditional treatment of your
Right.
gabapentinoids or like that. So in that case, sometimes the patient might be very intense pain. So we have to depend on these agents. See,
Okay.
as I already said, the literature is very scarce on these issues, but still people have used it, and there is published literature regarding that. So, but however, the dose is little less. Suppose in case of a ketamine, if you use in adult, normally we use as a sometimes give a bolus of 1 mg per kg, and then subsequent infusion might be 0.35 or mg per hour. But in case of the children, that normally the dose is little half, suppose in that case, if
Okay.
that have used in that the dose. Same for the lidocaine also, it has used in that way. Suppose normally that 1 to 1.5 milligram per kg per hour that normally used, that the dose has reduced, that is around 0.24, 0.5 dose like that, or 0.84 mg per kg per hour. So again, it has a role in those cases, that is the along with the other analgesic, co-analgesic, it has definitely a role. However, the studies are less, but there is more and more studies that is reporting of that. So that can give a good evidence for use in certain or
What about transdermal patches? That's very commonly used for adult cancer pain patients. So do they have a place in the management of pediatric cancer pain?
Yes, exactly. Same as the transdermal, because nowadays you have seen that a buprenorphine patch or a fentanyl patch, obviously it is available in some of the hospital also. Even
And they
in
are available in pediatric doses? I mean,
no, dose is exactly, it is not as a pediatric dose, is the lowest dose as the requirement. Basically, sometimes in
okay.
pediatrics also, it may not be useful of the age base. Suppose Malo, the age is very small. So in that case, obviously, we'll be reluctant to use because the pharmacology you are not aware of.
Okay.
But the children have a solid tumor or something, tumor or osteosarcoma that is already operated or like that, might be a 8-year child, suppose, or 10-year child. So
Okay.
those cases you
Slightly
can
older children, slightly
slightly
older children, right? And Dr. Muthukumar again wants to know, can we use Dexmed for pediatric pain, cancer pain? Is there any literature available? Do you have any experience yourself?
Dexmed exactly. See, if you see, as already I said, Dexmed in any pain. Suppose the pain in cancer pain is two type. So the pediatric pain itself is not exactly related to your cancer. It might be the procedural pain also.
Yes,
So
yes.
obviously, sometimes the procedure undergoing, suppose a biopsy, or sometimes the patient is going some treatment related to that. It has a role. Suppose you're giving a constant sedation,
Yes.
and analgesic dose can be used. So no
Yes,
doubt.
so our experience in pediatric patients with Dexmed is actually increasing, and we have a lot of
Exactly.
experience. It's not a very good analgesic by itself, but yes, because it has
As
a
it
lot of
was.
other advantages. It is sympatholytic, it is anxiolytic, it is sedative, some amount of analgesia. For
So
procedural pain, it is a good adjuvant to add
yes.
to other modalities. So
Yes.
yeah,
So
yeah,
it's per se in other perspective, it cannot be because no any other preparation is there. Only IV preparation is there.
yes, yes.
So it's in a very definite role when there is a procedural sedation or something like that.
Yes, thank you so much, Dr. Debesh. Dr. Nitin, I have a small question for you. Your talk was very interesting, and you talked about post-surgical pain, which to me is probably the most interesting because I, as a pediatric anesthesiologist, do encounter these patients with chronic post-surgical pain. What I would want to know is there any screening tool you talked about, and also Debesh has talked about nociceptive pain as well as neuropathic pain. Is there any screening tool, which is validated in children? Because these screening tools are very well validated in adults. But to distinguish between the two kinds of pain, are they validated in children also?
So, ma'am, we follow a lot number of tools for detection of neuropathic pain, like Pain Detect tool and other
Yeah,
pain sports tools. But basically, when the tool is having only the component in which there is an interview or the
right,
patient has to write,
right,
these are not applicable for pediatric patient because they may not give the total picture of the patient. The patient may not tell about the exact symptoms that he's feeling. So
okay,
there are there's one score that is Leeds Assessment of Neuropathic Lines
yes,
score.
yes, yes,
So this is basically a combination of symptoms as well as assessment. As I already mentioned in my slides also, that
yes,
assessment has, with the help of the assessment, now we are able to differentiate between, as we were all considering all the patient as neuropathic. Now we can say 50% are neuropathic and 50% are nociceptive.
right,
So until unless we assess these pediatric patients who are not able to report their symptoms verbatim, so this will be like DN4 questionnaire,
yes, yes,
DN4 scale and line
yes.
scale. These are the two important scales that should
So
be used
Lance,
for.
Lance has a good sensitivity and specificity also.
Yes, ma'am. Yes, ma'am. Lines ideally should be used in pediatric neuropathic detection, and in adult we usually go for Pain Detect tool, ma'am.
Okay. So from what I understand from your talk, because you've talked a lot about preventive aspects, every person, every anesthesiologist who's dealing with pediatric patients should have this information about post-surgical pain, because the prevention starts right from the time you assess the child for the first time, the first surgery undergoes. We cannot re-emphasize and overemphasize the importance of this fact. And most pediatric anesthesiologists are unaware of this high incidence of chronic post-surgical pain. So I think they should be made more aware of why it is so important to actually prevent pain right in the first place. So also, is the
Basically, ma'am,
trajectory,
I think the awareness should be not
you
only the
quoted a
anesthesia
very
body.
high incidence, 50%
Awareness has to be with
is
the surgeons also.
huge, is unimaginable, that whatever you are doing with these patients, these chronic, the chronic post-surgical pain is likely to result in every third patient or every fourth patient. It's scary just listening to this statistic. So I think we must be more sensitized to the fact that a large number of our pediatric patients can develop post-surgical pain, and we should be more cognizant of its management. Train the surgeons also. The surgeons must be equally aware of the entity of post-surgical pain in pediatrics, because they sometimes are a hindrance to using procedures in children. They are more, they have to be sensitized as much as the parents have to be.
They are
So,
mostly focused on the pharmacological, but as a pain physician, we are not only focused on the pharmacology treatment. The wholesome assessment of the patient is not being done by the surgeon, mostly. And
yes.
I'm sorry to say that.
Yeah, we've all been through that. And since you managed to, you've just mentioned the pain physician, I would like to ask Aanchal, do you think a child suffering from chronic pain should seek the help of a specialized pain physician? Or What is your opinion? I mean, you've seen these patients, you've done intervention. Do you think all these children with chronic pain should actually seek can a pediatrician manage them, or should they be sent to a specialized person for their management?
Yeah, ma'am, actually, the chronic pain, as per, we know that, it's multifactorial. It has many causes. So, if it's cancer related or if it's post-surgical, maybe pediatrician can manage it. But I would say that if there is something where the pharmacology, has a limitation, pharmacology is not able to take care of that pain, and you think there are, and even if, a thought that is there any intervention which can decrease the medications, or is there any intervention which can help the medication to be stopped, or patient is getting side effects from these medications, but then patient should be sent to a specialist, a pain physician, which is specialized in doing, or, able to do those interventions that we were talking about.
Okay. Are these interventions really different in children than they are for adults? Besides the dosages and all, is there any other difference which you feel as a practicing pain physician who deals with children? Is there anything difference in this intervention in children?
More than 12 years, I would say, not much difference, because you can talk to the patient, you can make them understand. But if you have to perform an intervention less than, 12 to 10 years of age, then probably you have to get an extra sedation. You have to be just aware of the anatomy, that if you're doing intercostal block, you can get pleura really early on, rather than, even a cough can, have your needle pass through that pleura. So just or the tab block, muscle layers are not that strong as you see in the adults.
Yeah.
For tab block, you have to really use that ultrasound and go a millimeter by millimeter. So, and sometimes the transverse abdominis is just a thin layer.
Yeah. So
So
you would want your child to go to somebody who has experience in dealing with children, whether it's just for pain or for, like it is for anesthesia. I think even for interventional pain procedures, particularly when it's talking about chronic pain, I think a pediatric pain specialist is the way to be.
that's the future, yes.
Okay, Nitin, I have another question for you. I want to know what exactly is the role of regional anesthesia. I mean, is it truly protective? Because we are going ahead in a big way for regional anesthesia. Everywhere we're just talking about regional anesthesia and ultrasound guided blocks and everything. Do they really, is there any evidence to say that they do protect against chronic post-surgical pain?
Ma'am, as I already mentioned, ma'am, if we start beforehand and continue in the post-operative period, the period is very important. In the post-operative period, till what time you have to continue, and that is the gray area that we need to explore. So till what time the inflammation is reduced, so it is 3 days, it is 4 days, till which time we should have to continue these medications, so that we prevent the sensitization of the nervous system. So this is that area of the research that is now being focused on.
Okay.
So we have to focus on the parameters which tell now there is we can just hold on to our epidural infusions or the block your peripheral continuous block. Now we have to reduce it and then we can stop it.
Okay.
So now we are going on that thing. So earlier what we used to do 24 hours, 48 hours, it was arbitrary. And after 24 hours, we would remove the catheter. But now we have to assess. So this assessment, how to assess now this patient still requires. So this is a composite research area that we need to find out.
So
there is a role, ma'am. There is a role, but the duration is important.
Right. Food for thought and new topics for thesis are growing in my mind as I listen to these talks. Debesh, you come from an extremely high-end center. You are at the apex of the pyramid. Do you have a separate pain clinic for children?
Ma'am, as you know, as per the pain is concerned, the scenario is something that you have to establish the pain as a whole, or pain is a specific role in anesthesia as a subject, if you consider.
Okay.
So now I consider the anesthesia pain medicine critical is really, it is a conglomeration of the three independent entity, and those have potential of enormous. So we are lucky that in the branch they're the three components, they have enormous potential.
Agree. See, we
So now, if you consider the pain as a specialty, still we are lagging behind as a whole the pain is. So only the pediatric pain is something that is, I don't think the near future you can achieve that. But I must say that again, awareness regarding that the chronic pain, as you are dealing mostly with the chronic pain in adult populations, the normally the referral everything. But again, we are into the awareness. We are getting a patient from the ward or something that have a pain is persisting, and still, then when the physician or the surgeon they takes their hands off, that I cannot.
No, and majority of these chronic, at least the cancer pain children, the children who come to the hospital with cancer pain get diverted to the pediatrician.
I don't think that is no, that is not an ideal situation. See,
that is not an ideal situation.
no.
So there is a lot of potential for work
There
there.
is a lot of potential.
Yes,
Even
because Nitin also runs a very successful pain clinic. Dr. Baljeet sir has been running a pain clinic from the time I was a student. He's been managing a pain
yes,
clinic. But somehow the pediatric patients don't come to these pain clinics. They go to the pediatrician. They, yes, go to the surgeons occasionally, but somehow majority of these cancer pains are being managed not by the pain physicians, but by the pediatricians, at least in our kind of setup. And I think, as Debesh has also said, so I would love to hear what Baljeet sir has to say, since he's been managing a pain clinic for so long. How many pediatric patients did you see, sir, over a period of time?
I would say very few. I
Very
fully agree that most of these patients, either they get to the pediatrician in case it's a non-surgical pain,
Yes.
or pain related to surgery, or else the surgeon, they go to the surgeon, and surgeons keep them very close to their heart. They would never send it to pediatric pains or the pain
to the
specialist.
pain physician, yes. They don't come to the pain physician. So
They do not. They do not.
Right.
That's unfortunately, I think it's a big stumbling block. And you very rightly said that the surgeons also need to be made aware that the
absolutely.
of pain is now available. It's not just that you give drugs at your own, with your own thinking. Now it's a science in itself, and uh, it's a growing branch. Earlier, they had a lot of difficulty accepting that pain physician for adult patients, अरे क्या है उसमें, give some drug, give diclofenac, give this, give that. But now they have agreed that they sometimes have a monkey on their back, which they need to offload. And that's how the patients get to the pain clinic, adult patients get. And I think the time will come when they will realize that, yes, pediatric patients also have a need for management.
Absolutely. And since more and more sicker patients are coming to the hospital, they are surviving, therapies are improving, I think we are going to see a quantum increase in the number of pediatric patients coming for chronic pain therapy. So it's been a very enlightening session. Thank you so much, Dr. Nitin, Dr. Debesh, and Dr. Aanchal, for those enlightening talks. I'm sure whoever listens to this webinar will benefit hugely from the academic content and the discussion that we've put forward. I thank you all, and I hand over back to Baljeet sir for his expert comments, and thank you so much.
Thank you, ma'am.
Thank you so much. I think what about comments? There has been a very nice discussion following the three excellent talks. All the three speakers did a great job with the topic that they were assigned. Dr. Nitin described, a lot about the post-surgical, pain, chronic post-surgical pain, but what are the causes, the pathophysiology and everything. See, unless we know what is the pathophysiology of the pain, we probably cannot do full justice to the management of that kind of pain. And then Dr. Debesh Bhoi, dealt with the cancer pain. Although the number of cancer patients probably are relatively less in number than the adults, but yes, pediatric cancer patients are there, and of course, their pain also needs to be treated. And Dr. Devesh very nicely highlighted as to what are the various strategies that we can have for this group of patients. And then Interventions, yes, Dr. Aanchal explained the interventions, and she highlighted the role of not just the interventions, I mean, apart from the pharmacological management, the psychological and physical physical intervention as well is equally important, whether it's in the form of yoga or, dealing with the psychological issues. I fully agree with her that yes, these interventions are technically challenging. As she has very clearly mentioned, some of the tissues are not very well developed. Some fascia is not very well developed. Moreover, all the structures are lying much closer to each other as compared to the adults. So accuracy is something which is very, very important here with regard to placement of the needle. And that's what makes these interventions challenging. But well, what is the challenge? We have to meet it. I mean, we meet so many challenges in management of patients, whether it's during anesthesia or in any other field like resuscitation. Well, we are up to challenge, but yes, we must realize that yes, whenever we are taking up a patient for pediatric pain management intervention, for that patient, so we have to be very, very alert. Ultrasound is a great boon with regard to these interventions, and I think that's what makes the interventions safer. All the three speakers have, given an excellent overview of the subject that they were given to, and very expertly moderated by Dr. Ranju Singh, I must say that. There's a lot of food for thought that all the speakers have given, and I think it's about time that we have some food for the stomach too. So, on that note, I thank all the speakers for
Thank you.
their thought, and beautifully moderated by Dr. Sanju, by Dr. Ranju Singh. And over to you on behalf of Indian College of Anesthesiologists, the president and the entire leadership. I thank all the speakers and the moderator. And of course, I always, as I always used to forget, not to forget this time, Ms. Ankita from Clarinet, because they are our digital partners, and they help us in bringing this to all our participants. Thank you so much. Good night. Stay happy, stay healthy. God bless.
Thank you, sir.
Thank you, sir.
And Happy New
Good
Year
night,
to
sir.
all of
Thank
you.
you.
Thank
Thank you
so
so
much.
much.
Good
See
night,
you in the
ma'am.
next year.
Thank
Thank
you
you.
so much.
Happy New Year, ma'am.
See you after a year.
Bye.
Thank you. Good night.
Okay, good night.
Thank
See
you so
you.
much,
Bye.
everyone.
Thank you.
Thank you so much for extending us the opportunity to host the session. So with all your permission, I would like to sign off here. Thank you, and
Thank you,
looking
Ankita.
forward to
Thank you.
host you again.
Thank
Thank
you.
you so much.
Good night.
Bye-bye. Good night.